Round 6.
Yeah, my name is Julie. I'm from New England QIN-QIO. I'm going to be your moderator for today's webinar, which is Interact Session 8, Decision Support Tools. As many of you are aware, the Interact initiative is an important results-driven work that many hospitals are requiring for their preferred providers to complete. Interact has proven to lower readmission rates when the program is followed and the tools are utilized. The Quality Innovation Network Quality Improvement Organization works with healthcare providers, stakeholders, and communities across New England on data-driven quality initiatives in order to improve patient safety, engage patients and families, and improve clinical care at the community level. Thank you so much for joining us today for our 8th session out of 9 for 2017. Before we begin, just a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation. We will take questions at the end of the presentation. I'll provide you with instructions on how you can ask a question over the phone or pose a question in the chat box. Please be sure to send questions to all attendees. At this time, I would like to introduce Sheila Eckenrode. Thank you.
Thank you, Julie. Welcome, and we're glad you're here. We're going to talk about changing condition file cards and decision pathways, Interact tools for decision making. So today's session objectives include understanding how to use the Interact change and conditional file cards and care paths, develop a plan for implementing the change in condition file cards and care paths on each of your units, understand the importance of using SBAR tool when reporting a change of condition to the MD, APR, and PA, and during an acute care transfer. We've talked about SBAR in a couple of these sessions. And we're looking forward to an update from each of you on the progress made in your individual facilities. Okay, I want to take a moment to talk about the requirements for the Interact participation certificate. Just to remind everyone, the requirements include minimum participation in the Interact webinars, attending 7 webinars out of the 9, and 2 may be viewed online, which means that you need to attend 5 live webinars. We need you to send readmission data to Qualidigm for at least 4 months, 4 months worth of data. You can send it once, as long as it includes 4 months. And to do that, you enter the readmission data into the NNHQI Safely Reduce Hospitalizations Tracking Tool, and just check the Data Use Agreement checkbox so that we can access your readmission data. So we really want you to do this so you learn how to use this tool, you learn how to pull the reports off and use them yourself in your facility. If you're having trouble with that, please feel free to contact me or Florence, especially Florence. She's an expert. She's our subject matter expert on the NNHQI tool here at Qualidigm. Lastly, we need you to have your nursing home administrator complete the Interact Tools checklist to verify which Interact tools have been implemented in your building. And since we're coming to the end of this webinar series, our last webinar is going to be November 29th. I want to take a moment to talk about that tool, that Interact implementation checklist. Here's a slide that tells you where you can access the Interact webinars after each session if you need to catch up. All right. And so let me talk for a second about the Interact implementation checklist. Go onto the Interact website, which is now administered by Pathways. You can print out this checklist. And it's going to look like this. So what we're asking you to do, along with your administrator and DNS, is to check off which tools you've implemented, and are they implemented throughout the facility or just on some units. This really is an opportunity for you to reflect on your progress and take a moment to see where you are. Please answer it honestly. You're going to get a participation certificate if you've implemented all the tools or if you've implemented one tool. But what this really is about is taking a moment to assess where you are and strategizing where you want to go next. So if you've gotten Stop and Watch and SBAR implemented on all units, next in line may be changing condition file cards and care paths. Take a moment to look at what you've done so far and celebrate that success. Spread the word out throughout your facility that, look, we got this done, and this is what we want to do next. The second part of this is an outcome assessment. So within your Interact team, look at the outcomes on this checklist and decide which ones you feel have been accomplished in your facility. So did the use of Interact implementation tools improve communication, improve nursing evaluation and assessment, improve documentation? And again, this is an honest assessment for your use. There's no grades are given. It's pass, fail, and if you just put your name on the pass, you pass. But take a moment to see where you've been, assess that, and take a moment to strategize where you're going next. All right, with that, I'm going to turn this over to Florence, and she's going to talk about these tools, care paths, and acute changing condition file cards.
Good afternoon, everyone. Thank you again for joining us on this lovely, great New England day. I will be talking to you about the decision support tool. And as Sheila said, the acute change in condition file cards is exactly what they sound like. So they're built like index cards, and you can actually laminate them and put them in a box, or have a hole punched in them so that they're easy to see and follow. The key to this is making sure that they're somewhere where your staff can access it. I've been in facilities where tools have been placed in binders, and because there's so many binders on the unit, no one uses the tool. So when I ask, where is it, the supervisor can tell me where it is, but the staff that actually need to use it do not know how to access it. And we talked about this way in the beginning of this whole collaborative about making sure to communicate to staff when new tools are being introduced, where they can find it, develop your process, and remove whatever the previous process was so that staff does not fall back to what they're comfortable with. And then we'll also, and I'll go into the file cards in more detail later. We'll also review the care path. And this is all designed to provide your staff with evidence-based practice on how to take care of their residents and treat them place. So the acute changing condition file cards can be used by all nursing home licensed staff and primary care clinicians. So your APRNs and your PAs can also use these cards. They provide guidance on when to communicate changes in status to your medical directors, your downstream providers such as your nurse practitioners or your PA. They recommend placement, we recommend that it be placed at the nurse's station or on the med cart, which is where nurses spend 90% of their time when they're in the facility. So again, if you can make a ring out of it so that it just hangs off the med cart, it gives them an instant place to look for information. And then the 4x6 laminated cards can also be put in a flip chart or in a Rolodex. I think we all still know what Rolodex looks like. And can be placed at your nurse's station by the phone. So what the cards look like, and you're seeing an example of it here, talking more specifically about laboratory tests or diagnostic tests. It gives them a baseline of numbers that would require either immediate response and reporting or not, something that they can just wait till the end of the shift or something to report upon. Now, what I would recommend, these numbers are based on the folks that interact. Oh my goodness, I just lost my word. Their experience as they've gone through all the different testing, these are the numbers that they recommend. Please talk to your facility, talk to your medical director and your downstream providers, your director of nursing, and make sure that these are numbers that you can work with. If you need to change the numbers to make it fit your facility, please do that. We don't want to be practicing outside of your facility's scope and what you're allowed to do. Right there with me. So the cards go alphabetical, and they have different symptoms. As you can see, there's all the symptoms that start with A: abdominal pain, abdominal distension, tenderness, abrasion, agitation, altered mental status. It's change in appetite, asthma. So it's real easy to go flip through the cards based on whatever symptoms you're having. It talks about what needs immediate attention and what's not immediate, what you can defer till later. I think I'm going to keep saying this throughout this session, that this is really important when you have a new nurse. It really gives them support and allows them to be able to practice independently. And then it continues on with, just want to give you, samples, H, I, and J. So if you have someone that's having hallucinations, someone that fell and maybe hit their head, what you should do. I've been in facilities where a resident has fallen and immediately the first reaction is to get them off the floor. Well, you need to assess what's going on. If they hurt their head, there's a certain way that you should treat them, and again, if you're a new nurse, you may not necessarily know that, so this helps you to figure out how to do it, when it's important to notify the medical directors immediately. Now, I think we touched upon the care path in the past, but to go into it in more detail, it provides guidance on recognition, evaluation, and management of the 10 common conditions leading to transfers. And these are also the 10 areas that really drive concern or anxiety in nurses when they're on the unit. It works well in conjunction with the change in condition files. It's important that you have buy-in from your medical director and other team members. So we had a facility during our first go-around of this about 3 years ago that took a look at all the care paths. As a team, they agreed that this was a great way to provide care. So they took the care path to their medical director and asked him to review each one. And if he agreed with what the directions of the care plan, of the care path, he was asked to sign each individual care path, then giving them the ability to provide care based on the care path without having to call the medical director every time. This was so successful that within a month and a half into it, the medical director came in and said, "Hey, how come no one's been calling me lately? My phone's been kind of quiet." And the director of nursing reminded him that, they had this discussion, he signed up on the care path, and that's how care has been driven since then. So this is a really, if you're able to do this, it could be the beginning of a QAPI plan and project for you. So you're seeing a sample of the care path. It really does direct care based on whatever the symptoms are and the evaluation that the nurse is performing at the time. It provides a decision tree for implementation of best practice. It's helpful to new grads, as I said, and it's also helpful to someone that's been out of practice for a long time and is starting to step their foot back into nursing practice. And it's also a great way to develop your policy and procedures if there's an area that you don't seem to have a policy and procedure in. So the 10 areas that the care path looks at is a change in behavior, which would be great for if you have a dementia unit. Dehydration, which at this time of year is important. Falls, we all have to deal with falls every day. Fever, GI symptoms, symptoms of acute mental status change, CHF, lower respiratory infection, shortness of breath, and UTI. And I can just imagine all heads shaking out in the audience there. So, strategies to help you in implementing this and making it part of your culture. Sorry, I'm moving it on to Sheila. I got so involved in it. Thank you. We'll open up for questions later.
We'll talk more about that. I wanted to take a moment, if I could, to talk about change theory and how people change. And I know you've probably heard a lot of different theories about organizational change and changing culture, changing behavior. I know there's a lot of popular books like The Power of Habit and so forth. So you probably already have ideas on how change can be implemented in an organization. But I did want to take a minute, I felt, to do justice to the work that we're doing here, to reflect on one theory and sort of one strategy for affecting change. So in the organizations that we work with, we're really in the business of manufacturing change in healthcare here at Qualidigm. And we've seen it done well, and we've seen the stumbling blocks to change in culture, and anyone who's tried to implement a change, especially those of you who are in management, have many tales to tell, probably of things that you implemented, and a year later you come back and it's just the way it was before the new implementation, and you just say, wow, there's a powerful pull towards sameness here. And that's true of organizations. They will always go back to their setting point, almost like water finding its place. So just some things to think about as you implement these changes in your organization. These are recommendations from a group out of the University of Texas from a book called Leading at a Higher Level. And they're pretty tried and true and pretty well accepted. And you'll find the same sort of concepts in any change theory you might learn about. So, strategies for change. How are we going to go about this? Well, the first thing they talk about is over-communicating. So you want to just make sure every single person knows what's coming. Everyone knows that SBAR has been implemented. The nurses, the supervisors, the aides, the housekeepers. You really want to get that message out. This is the point where you explain what the change is and why we have to do it. So we're going to implement this new communication tool. We have to do that because we're going to become an interactive facility. That's one of the things our hospital partners are asking us to do. The next thing people are going to want to know is what's wrong with the way we do it now. And that's what we have to talk about. This is more effective. It provides prompts, so reporting out is more thorough. And the other question people will want to know about is when is it going to happen? How fast do we have to implement this? So this is think of this as the fast part of the explanation of change, what we're doing, when we're doing it, why we have to do it. The second phase is getting a little bit more personal, because after people have had a moment to process that information, here comes the change, this is what we're going to do, this is why, the next thing we all ask ourselves is, what's in this for me? How is this going to affect me? How is this going to make my job easier? Will I be able to do this? Will I win or lose? Is this going to make me look good? Is this going to make me look bad? Do I have to learn new skills? How am I going to get that done? These are very natural concerns, and we've all experienced them, but there's something very powerful about letting people get that out in the open. So if you can foster an environment where people can say, well, why should I do this? How's this going to help me? This is going to make more work for me. Even if it is, even if the answers aren't completely positive, giving people a moment to kind of get that off their chest can be a very powerful thing, because what we resist persists, and when these feelings of conflict and resistance to change kind of go underground, they can become a powerful force pushing you back to sameness. So you want to give people an opportunity to talk about the change in a very personal manner. All right, after that, the next set of questions we're going to talk about is planning the action. So this is where we say, what do I have to do first? We're going to get the forms. We're going to train the staff. Going back to that SBAR example. How do I manage all the details? What happens if it doesn't work? What's my default? Who do I call to complain about this new process? Who do I tell about what's going wrong? If it doesn't work as planned. People at this point need some reassurance that this is all natural, that mistakes will be made, it's something new, it's like riding a bike, you're going to fall off it. This is a point in time where your staff really needs to know that their efforts are appreciated, that this is going to be a bumpy road, but we're going to hold on, we're going to go forward. So planning the action, mapping it out. So far we've let people know what we're doing and why. We gave people an opportunity to talk about how it's going to affect them, to vent their fears, frustrations, and concerns. And now we're going to talk about exactly how is this going to happen. What do I do first? What do I do second? Who's going to help me? Next up, we're going to sell the change. And how do we do that? Well, this is really important. And it's a topic that's dear to my heart because I'm talking about data and I'm talking about measurement. At some point, you want to be able to go back to your staff and say, listen, we asked you to use SBAR, and guess what? 50% of the report offs last month used SBAR. People want to know it's getting better. It's like being on a diet. You've got to weigh yourself. You've got to see some progress to kind of keep the momentum going, to keep hope alive, if you will. People want to know that a change is being made. And it can be a formal counting of how often a tool is used, or it can be something as simple as, geez, I met the medical director the other day, and he mentioned that the ED staff is so pleased with the red envelope. Some anecdotal information is helpful too. Charlotte used Stop and Watch, and she caught this patient going into CHF. We prevented a worsening of his condition. She was really on the ball, and she filled out that form, and because of that, the supervisor got it, and then got to the APRN the next day. Tell those stories of success, because people need to hear that. People need to know that their pain is for some good reason, and that it's making a difference. Okay, so once you got this kind of going, you want to collaborate smartly. You want to have people talk about what they see happening. You want to hear from your staff, what's working, what's not, and giving people a chance to talk about how it could be done better. It's seldom the case that we implement something new and it takes off in its original form. Most of the time things have to be refined, and that's the last step in this six-step process. So, we talked earlier in this webinar series about PDSA cycles and starting small tests of change, taking something like the file cards, trying them on one unit, one shift, seeing how that works, seeing whether or not they stick, and how the implementation goes, and then refine it. So you're planning out a change, you try it, you get some feedback, you see whether it's working, you refine that change, you refine your strategy. So I hope that you think about this going forward and implementing these tools. I've seen so many times that the folks on the top in any organization come up with a great idea, and if it is a great idea and there's a real reason to do it a new way, but it never filters down to the bottom. And in order to filter it down to the bottom, you've got to keep talking to people about it. In the beginning, you have to give them information, over-communicate, let them talk about how it affects them personally. Towards the end of the change, you need to get information from the people implementing the change. So the last three steps are all about you asking, how's it going? What do you think? How could it be done differently? What do you think of this tool? And be open to hear some negative feedback as well as positive feedback. So I hope you think about some of these things as you go forward and implement your care paths and change and condition file cards. So that brings us up to our sharing session. Just going to take a moment to talk about last month's homework, and then we'll hopefully hear from you folks. I'm very interested in advanced care planning in your facilities. We had talked about the Interact tool last time, and I know that many facilities already have some processes in place to encourage advanced care planning. So I'm interested in those best practices. I'm interested in hearing about what's working for you. And we'll talk about this month's homework as well. So last month, we asked you to download the advanced care planning tools and the communication guide and look at them with your team and show them to your staff and see what they think about them. If you are going to implement the Interact Advanced Care Planning tools and communication guide, we ask that you and your team discuss how and when the staff nurses, social workers, supervisors, etc., will be educated on these tools and decide which unit to begin using these tools. Again, last month we talked about one of the most powerful aspects of these tools is to build in a script for people who might find it difficult to approach residents and their families on this subject, but it also prompts you to revisit the idea of advanced care planning at various times in your residence stay. So I know that all of us in long-term care are really good about that first set of advanced directives when someone is admitted to the facility, but within 3 weeks, within 3 months, the resident's medical status can change dramatically, and very often we don't revisit that with the resident and their family. We don't reopen that discussion and talk about the changing status, make sure that those advanced directives that they came in with are still meeting their needs and still is how they want to be treated. So we talked last week about looking at those tools, developing a timeline for their implementation if you're choosing to implement them. And if you're not, I hope that people will at least begin discussing when advanced care planning is done in your facility. Is it done after each hospitalization? Is it done at every resident care conference? Some building into your process a way of revisiting that, because people's needs change and their status changes, and those are decisions that you never want your residents or family to have to make in an emergency department or rushed in a hospital. You want people to have control and put some thought into these incredibly profound and important decisions. So that was last week's homework. Last month. Thank you, Lauren. Lauren is reorienting me to time, person, and place. The other thing we asked you last month was to look at the readmission tracking tool that I mentioned at the beginning of this session, make sure that you're able to access it, that you're getting your data into it. And again, if you're having any trouble, please call us and we will walk you through it and make sure that you get that done. We're here to help. All right. So this is the part of these sessions where we ask our participants to talk a little bit about how it's going with interactive implementation. So the first thing I'd like to ask is, does anyone feel that they have a really good process in place for advanced care planning with their residents? Does anyone feel that they have something important to share about how they get that done? How it's prompted? Who initiates that discussion? Is it your medical director? Is it your social worker? Do you have stories of success? Do you have stories of where you've seen things go badly? Has anyone tried using the Interact tools, and what did they think of them, or if you've reviewed them, how did you find them? So I'm going to open this up and jump in. Your lines are unmuted.
So just press #6 to unmute your line to give us an answer.
Hi, it's Janice at the Lutheran Home. How are you?
Hey, Janice. Thank you, Janice.
Hi. So I wanted to just kind of go over our procedure in that. Several months ago, we revised our advanced directive form. We found the form to be extremely confusing for the nurses to understand and complete. So we revised that form so we have our code status on the form, and we also have an area on the form when appropriate to address comfort measures, which was not on the previous form. So that was one thing we started kind of ahead of this advanced care planning session that we had a month ago. What we do on admission is the admissions department tries to elicit from the responsible party living will, POA, that kind of information ahead of the resident coming to the facility. When they come to the facility, we try to get copies of any of those documents. We ended up in our medical record putting a section in our medical record called legal under a legal tab, and we moved that to the front of the chart so it was easily accessible. We found that these documents sometimes can get lost within the volumes of medical records, so we moved that to the front of the chart. So when you open up the medical record, it's the first thing that you're going to see is the advanced directive and any of the corresponding documents, living will, POA, should be copies, and we put those into plastic to protect them. The conversation on advanced care planning is done on admission. Our supervisors initiate the conversation and talking about, what was their code status in the hospital, what do they want to be, and we work in conjunction with the physician, whether it's a medical director or a primary care physician, and we try to get this done immediately on admission as soon as we can get this document filled out for their wishes at that time. We get that completed and witnessed and put into the chart. Currently what we have in place is we will revisit this document at care plan meetings quarterly. We will revisit this document with acute change in condition. For example, obviously if a resident comes in and they're a full code and they've had a significant change in condition, and maybe the family and the resident are not wanting to, go to the hospital, then obviously we need to readdress that. And put orders in place in advanced care planning for do not hospitalize and possibly comfort measures. In our comfort measures section, we actually don't have it just say comfort measures only. That was another area we revised to be more specific about what those wishes are, because most families and even the residents don't understand that. So we have ours specifically written out. So if somebody asks for comfort measures only, they can specify below what those wishes are. Whether that's no IV, whether it's no tube feeding, no blood transfusion, no lab tests, no weights, no I&O. And we educate them on each of those areas and what's appropriate for them and what they feel comfortable in specifying at that time. So that's kind of our process right now. We can continue to look at it, and, you know, we'll refine it, you know, as we see fit. But I know that, you know, initially, like I said, several months ago, I was very concerned by the confusion on the form, and nurses not even understanding the form. And if they can't understand the form, then it's hard for them to explain it to the families and the residents. So we took that as our initial step, and we've kind of grown from there. So that's kind of our process right now. You know, we'll look to, you know, obviously any feedback is most helpful. Always looking for opportunities for improvement.
That's great, Janice. I just wanted to ask, who were the people involved in refining this document?
Actually, the medical director and the unit managers, the director of nursing, and myself. We all kind of sat down, and I gave them some of my thoughts, and then we kind of just ran through the process. Medical director wanted the CMO written out a little bit differently, and she had some great thoughts on that. So, you know, that's why we specified below the wishes. So it was kind of a team effort, as anything that you need to do in a facility to get buy-in. You kind of have to go to the team. And then obviously once we settled on what the form was going to look like, we educated the nurses, made sure we took the old form out of circulation, so that didn't keep coming up. That's very important. And we educated the nurses on the fact that the form would look a little different than they're used to, but why we felt the need to do it, and most of them were on board with it because the other form was problematic.
That's great. Thank you so much.
Yep, you're welcome.
Does anyone have any questions for Janice? All right. Is there anyone out there that wants to share their process that they're using? Donna Grant, are you on the call? What is it, star 69? Pound 6 to unmute your phone. Okay, how about Ed Martinez? Are you on? You shared a lot of information with us last session, so I wondered if you want to carry on with that.
Hello?
Ed?
Hello, can you hear me?
Can hear you.
Okay, awesome. How are you?
Great, how are you?
Great.
Thanks for taking on the challenge. You want to tell us what you did with your advanced care planning?
Well, right now with our advanced care planning, we do have our DNR forms in front of the charts, just like how Janice explained earlier. So we do have that in the front, and part of the admission package. So that kind of gets tackled as soon as any new admissions come in. So that covers that end, so no one's left, stuck between the folds. And in addition to that, we also add for any existing residents, we are conducting a program where we're facilitating, just filtering out each chart, whichever DNR they have. We conduct an audit with them, and we're just adding them as we go along. My DNS actually has a statement she would like to make also.
Hi, Florence. It's Chris Regan.
Hey, Chris.
So one of the issues we have related to advanced care planning is our population in our facility has a large number of residents who have court-appointed conservators. So there's many folks that we think should have advanced care planning and goals of care addressed, but we frequently have huge obstacles because the conservators have to go through the court system to change people's code status or advanced care planning, and it's a challenging and lengthy process that we haven't figured out a way to improve or go around. I mean, sometimes, it's months on end, and it affects the quality of life of our residents, and we're sending people out to the hospital that we could very easily provide, comfort level type of care if we were able to have a simpler way to address that. So I don't know if you have any input or ideas related to that problem.
Where is your facility?
In what town?
New Haven.
In Haven.
It really does tie your hands, and it ends up, like you said, causing your residents and your clients and your patients to have to suffer, needlessly. I hear that a lot. I've experienced it. So I'm not really sure. It's almost something that has to be done politically in changing the way that court-appointed conservators work. Because you appoint them and then you don't allow them to make all the decisions as they should.
And frankly, the local probate judge historically has not always seen the light as far as quality of life decisions when it comes to our population. So even getting to the point where that process is initiated, historically it doesn't always go the way we think from a ethical standpoint that it should go. I don't think he's a fan of comfort measures in hospice.
Again, it's education.
It's a general statement. I don't know that for a fact.
Right.
Well, interestingly enough, I was at a community meeting, a community of care meeting in Middlesex this week, or I guess it was last week, and the probate judge came to that meeting and he gave a presentation on conservatorship and talking about probate and conserving a person or an estate. And he got a lot of feedback from the people in that room that, when a conservator reaches out to probate and says, listen, I have to change someone's status, they don't have weeks and weeks and months to do that. It has to be done within a day or two at the most. So I guess what we're all going to be tasked with going forward is to work with those probate judges. And that's interesting that you brought that up, because I just was talking to Judge Marino, and I think I want to give him a call now and talk to him a little bit about how probate judges, where do they get together? Do they have a probate judge club or some sort of collaborative? Where do they gather? And can we talk to them about this issue? And so we open up this conversation. In Middlesex, that judge was very open to becoming more responsive, and he kind of said to this group, listen, you call me and tell me what's going on and tell me that you need immediate assistance in changing someone's code status or consent for surgery or whatever it is, and I'll realize what that means now, and I'll try to respond within 48 hours. So I wonder if there's some sort of collaborative where those folks get together and I could ask him to talk about that, or maybe your call then can go, and maybe we'll bring you. And talk to them about what this actually looks like on the other side. When all I'm looking at is a piece
More than happy to join you.
Okay, good. When all I'm looking at is a piece of paper that's requesting a change in status, that's a very different experience than I'm sitting at a bedside watching somebody writhe in pain or die a long, protracted death and lose control over the way they die. So I guess we need to make this more real for these folks, right?
Right.
All right. Well, thanks for that idea. I'll take that forward, and I'll contact Judge Marino and see if there's a place. It's going to be very different depending on what town you're in, right? And each town that the probate judge has kind of, it's a sovereign status. It's like a kingdom, each one of those.
Yeah, rumor has it ours is maybe retiring soon, so maybe we'll get a fresh perspective when that happens.
Well, or maybe he'll have an experience where he goes to a nursing home.
Oh, yeah, there you go.
gets a bit of this firsthand, you know?
Yeah.
It looks very different, and Florence has told me about folks in, developmentally delayed folks, adults, and, who reach the end of their lives, and how difficult that is to, and, how we all struggle to advocate for people to have a good death. That's one of our goals in long-term care, correct?
Yes, it is.
Dignified and a comfortable death.
Rebound. All right, Julie.
I guess the positive thing is that people like you are advocating for your residents and helping them, taking care of them. Anybody else feel they have a good process or a process they want to improve when it comes to advanced care planning? Hello? I know from the acute care side, we have palliative care consults now in most of the large hospital emergency departments. So if you're sending someone and you're sending some information along with them in your Interact transfer form, you can request that, a palliative care consult in the ED. If that seems to be something that would be good, patients are going to the emergency department and being admitted directly to hospice. And that's a huge change, because it used to be you had to go to ICU first. That was when we practiced first you'll suffer, then we'll let you die. All right, anyone else?
Hello, is anyone still on the call?
Okay.
All right, any questions?
All right, well, thank you. Thanks for your participation. Going forward, homework for this session, we're going to ask that you review the acute change in condition file cards with your team. Please take time to do that. They're a wonderful tool, especially for new staff. It's kind of like a policy and procedure manual, ready-made, that you can just download off the internet. Best practices are continuously updated as new information becomes available. Decide on where you're going to put them, where they're handy, as Florence was saying, not in yet another binder. There's a dusty binder on a shelf that the short people can't reach. We don't want them up there. We want them, like Florence said, on the med cart and places where they're handy. And develop an implementation plan for staff education. If you're going to look at staff development for the next few months, this could be it. You could just go through these best practices for common conditions, ready-made staff education. Again, please download the Interact implementation checklist and get it to your administrator. After discussion with your team, what do you feel you've implemented completely? What do you feel you've implemented somewhat? It's always interesting to ask the staff what's implemented, because sometimes that's different than what we think happened and what actually has happened. But this is a moment to reflect, and as I said, whether you've implemented everything or implemented one thing partially, doesn't matter in terms of receiving a participation certificate. What this really is about is taking a moment to assess where you are now and strategizing how to go forward, remembering some of the things I discussed earlier in terms of change and how people change and what kind of information they need, and to get some buy-in. All right, and look at the outcomes too. I hope that you'll do that and get a sense of how these tools have affected your culture. Okay, if you find a gap in any of the areas on your implementation checklist, you might want to conduct a root cause analysis and really look at why the implementation of a tool hasn't taken. If you feel that you've implemented SBAR and take a moment to go to your 11 to 7 supervisor and have him say, what's SBAR? You know, try to figure out where things might have gotten derailed. And our next webinar, which I believe is actually on November 29th, isn't it? It says November 30th here, but again, I'm disoriented to time, person, and place. As Floyd pointed out. So it's November 29th, our next webinar. Please come prepared to share and to tell some stories. This is really important for you and for us as well, because that will tell us what we can do better next time around and how we can help make this happen. Again, our goal across the state of Connecticut, all of our goals, is to provide the best care possible for our residents and to implement Interact towards that end. And with that, are there any questions at this point? Okay, class is out early. Talk to you next month. Take care.
Thank you everyone for coming to our 8th webinar. As a reminder, we are now on social media. Visit us on Facebook, LinkedIn, and YouTube. When you close out of this webinar, the evaluation is going to pop up automatically on your computer. If you please fill that out right now, we'd really appreciate that. But if you don't have time to fill out the evaluation right now, you're currently sharing your computer with someone else, you're going to receive an email tomorrow with a link to the evaluation as well as a link to the event page on our website. PowerPoint presentation is in your day of details email today and will be posted on the website. Within the next 2 business days, the recording and the transcript of this webinar will also be added. Thank you so much again for attending. Have a great rest of your day. Bye.
The leader has disconnected. The conference will be terminated in 5 minutes.